On the population health outcomes, we're kind of looking at it in terms of higher rates of um, preventable diseases. Like I said, usually we can think about it from the lifestyle illnesses like diabetes and hypertension. Um, Being vulnerable, having those ecological and individual vulnerability, having poorer access to healthcare, having poorer quality of healthcare means that your risk of having your ability to make lifestyle changes is reduced as a result of your vulnerability, as a result of your poorer access to care or lower access to care, having higher barriers to care, and also lower quality of care. Then increases your risk of having diabetes. So you would find in a populations of people with increased vulnerability, them having higher rates of preventive or preventable diseases because of the way all of these structural barriers have kind of played in increasing their vulnerability and also exacerbating their vulnerability. And this all leads to the people in that population having lower life expectancy, but also as a result having, experiencing a lot of health disparities. And this is often seen with regards to race, ethnicity, socioeconomic groups, and also gender. Age also, with, especially when you're dealing with older people and having less access to healthcare. So, how are all of this interconnected? I talked about the interconnectedness of ecological and individual elements of the vulnerability framework, but I also talked about how that fits into access to care, how it fits into quality of care, and then health outcomes. But I would just kind of want to tie it all together. So, vulnerability, access to care, quality of care are all interconnected. I've kind of explained this. So, what then happens is that this creates the interconnectedness, creates a cycle that influences both health outcomes on the individual as well as population health, a population level. So this pathway of interconnectedness, you know, causes is such that having this vulnerability from a individual or ecological standpoint increases one's likelihood of experiencing barriers to healthcare access, and then having limited access to healthcare reduces your ability to prevent or manage health conditions, thereby worsening your health outcomes. And you having poorer quality of care is often experienced by people who are in the vulnerable populations, which happens as both happens as a result of a poorer quality, but also is a problem for having a poorer quality of health. Let me put it this way: people who have been misdiagnosed with an illness are less likely going to seek higher quality of care. Having the existence of poorer quality of care leads to increases one risk of being misdiagnosed. So that is how that relationship works. It kind of feeds off each other. So vulnerable populations have also, due to having historically poor quality of healthcare services, um, generally have a reduced trust in the healthcare system. So I talked about how the perception that you're going to be discriminated against, or the perception that you're going to have language barriers, may discourage people of vulnerable populations from seeking help. This all comes both with distrust. A lot of the times, these are historical distrust that happens many years ago that are still affecting those vulnerable populations, that would lead them into not seeking help, which then increases their vulnerability. Now, I want to mention that this historical lack of trust is not always specific to health, right? It's not always specific to health. Let's use, for example, if a vulnerable populations have experienced a lot of discrimination in other areas of their life, they would make the assumption that they are going to experience it in healthcare services as well because of history, that they know this has been something that's been they or people that are like them have experienced, and therefore they have very little trust in the healthcare system. So think about it from that perspective, not just in terms of reduced trust strictly in the healthcare system, but also reduced trust in overall societal interaction. So that would help in explaining what I mean by that. All right, so I'm going to use an example to kind of show interconnectedness. A low income individual that already has asthma, which is a individual needs act factor, that lives in a city with high air pollution, with high air pollution being the ecological disposition predisposing factor, will face limited access to specialty care. This limited access to specialty care is an access barrier, and as a result of having this limited access to specialty care, may experience or may receive less comprehensive treatments that could happen due to health providers having biases, which would be a quality issue, thereby increasing their vulnerability and thereby worsening their healthcare outcomes. So when you're thinking about vulnerability in that sense, think about it in terms of the interconnectedness of all of these elements of the vulnerability framework. So, population health management aims to improve health outcomes by addressing those root causes of vulnerability. So that's why it's very important to understand the vulnerability framework because it helps in trying to address those root causes of vulnerability. So, addressing the interconnectedness or the interconnected factors that create vulnerability is very essential as a population health professional or as a future population health professionals. It's very essential in order to help improve the health outcomes for both individuals and populations. So, by using the vulnerability framework, you are able to design targeted interventions that will address both ecological factors and individual factors in order to help break the cycle of health outcomes. So, in order to address how vulnerability interacts with access to care and quality of care, you want to make sure you've kind of paid sufficient attention to the individual and the ecological factor. You're not just going to focus on increasing quality of care, increasing access to care, because everybody is not going to interact with the healthcare system exactly in the same way, because of their ecological and individual factors will differ. So some people are going to be more vulnerable as a result of those ecological and individual factors. So now we've kind of really talked about vulnerability framework, for which I spent a lot of time in, because I really wanted you guys to understand it, so that when I start talking about vulnerable populations, you would understand why they are a vulnerable population. So there are certain populations that are higher risk of both, having either poorer physical health, or having poorer psychological health, or having poorer social health, or having all three of them. And a lot of this is as a result of the intersection of all the vulnerabilities that they may have. So, as a population health professional, it's very important that you are tailoring healthcare services in order to meet the needs of these populations, as that's the way to reduce disparity and to improve the health outcomes of the population. So there are common terms that are used to describe vulnerable populations. You have underserved, Usually, when we use the term underserved, we are thinking of it from the lens of these are populations that have limited access to healthcare services, and this could be either as a result of geography, as a result of finance, or more systemic barriers. An example would be racism or discrimination. Then you also have a term called medically underserved. These are communities that have a shortage of healthcare providers and services. This is very, very common in rural communities and also in low income communities. And then we have medically disadvantaged. This is a term that we use when we are looking at individuals with barriers that limit their access to medical care. An example would be people with physical disability. If the medical services that they have around them does not have any accommodations made for those with physical disability, they would be medically disadvantaged because the fact that the medical facilities have not made those accommodations makes it such that they then have barriers to accessing medical care. And then we have the term underprivileged. These are populations with fewer social and economic resources. I personally, I'm speaking strictly on a personal basis here, do not like the term underprivileged. The reason I don't like it is because it has a lot of stigma to it. It kind of places the responsibility of having fewer resources on the person that has fewer resources rather than looking at it from a societal basis to say there's a system that has been in place to make it such that this population have fewer social and economic resources. So I don't personally do not like that term. Underprivileged is not a term that I would willingly ever use, but is a term that is pretty common. I just so that's why I included it, even though I personally wouldn't use it. So, a number of examples of vulnerable populations will include racial and ethnic minorities, people who without insurance, women and children, those who live in rural communities or rural areas, homeless populations, migrant workers, those who are mentally or chronically ill, and people who have disabilities, and then people who are living with HIV/AIDS. Another term that we use, well, not a term that we use in kind of vulnerability, but it's kind of a term used for vulnerability, but less about individual, but more about on the ecological sense, is medically underserved area. This is usually in reference to communities that have a shortage of medical providers or healthcare services and providers. And the way to identify what a medically underserved area is this thing called the Index of Medical Underservice. So this index includes looking at percentage of people or percentage of the population that live below the poverty line, percentage of the population in this area that is age 65 and older, and infant mortality rates within that community or that population. And also finally the number of primary care providers per 1,000 residents of that area. So I have kind of talked about it, systemic racism, discrimination. Let me kind of shed a bit more light in it in talking about racism in healthcare. Typically, while there has been a lot of progress made in terms of overt racism, it doesn't mean everything is all kumbaya quite yet, right? It is not uncommon for people of racial and ethnic minorities to experience microaggression in their interaction with the healthcare service, the healthcare system, because providers may harbor implicit barriers that or unconscious barriers that they may not even be aware of themselves, and also where you have a healthcare system that is underrepresented, of people of color, or people of that racial or ethnic minority groups in the workplace, it kind of increases the likelihood that people of ethnic and racial minorities are going to experience some form of discrimination or prejudicial interaction with the healthcare system. So, so it's important to address racism in healthcare because of how it plays into health outcomes. And to do that, we need to consider things like increasing representation of racial minority groups, with healthcare professionals, having more healthcare professionals of color, but also having more healthcare professionals in leadership, so that it's not just being a foot soldier, for an example, but being leadership, being able to make policies, being able to make changes. It's very important that there's increased representation there. There's also a very high need for cultural competence, competency training. And then there needs to be a promotion of racial bias and how it impacts health outcomes. A lot of trying to promote racial bias is also in making people understand that just because you may harbor unconscious bias does not equate you being racist. A lot of the time, the people are too afraid of being seen as being racist that they do not examine uh, any subconscious or implicit biases that they may still hold because of the fear of, oh, I'm not racist, without having to really, really examine some of those unconscious biases, or some prejudicial, some kind of thought processes that may be discriminatory. So, academia also plays a very, very big role in trying to tackle racism in healthcare because it helps in educating future healthcare professionals, as you guys, on the importance of health equities. Trying to understand how all of this plays a role into health outcomes. So, reducing systemic racism and increasing healthcare access to medically underserved areas is very essential for us to be able to achieve health equity. Now we've talked about racism. Let's kind of talk about gender in healthcare. Women face poorer health. In general, we have higher morbidity rates. We also have higher prevalence rates when it comes to acute or chronic conditions compared to men. Some of the things, some of the areas that you see gender based health disparities will be in women having higher rates of short and long term disabilities, having greater number of days where their activities are limited due to illness and injury, and having more frequent episodes of infectious diseases, and also having differences in disease onsets and progression, how they respond to treatment. So gender disparities can be influenced by a number of things. One would be biological differences, social roles and expectations plays a very big role, especially with the view that women are caregivers rather than those who are receiving care, and therefore when a woman is sick, uh, illness may not be taken as seriously versus, let's use for example, when a child is sick or when a man is sick, because women are seen from that perspective of being caregivers rather than being the ones that are receiving care. And then there's been gaps in medical research, with medical research historically being done on men, and being, the idea that if this works with men, then it will work with women, and that not being the case. And then also women having limited access to reproductive health care and some gender specific health education. So it's very important that we address gender disparities in order to create, provide comprehensive healthcare services. So that's where we end with the first learning objective. This is very lengthy. I really wanted to take my time and explain, aspects of the vulnerability framework, and vulnerable population groups, because it's going to really help you in understanding health equity from and how that plays a role in health outcomes. So I'll do come back for the second for the third video in this case, where we're going to talk about the second learning objectives, and which we'll be looking at health concerns for homeless population and migrant workers. See you in a bit.